Ich hoffe, dass es geht, wenn ich auf Englisch meinen Vortrag mache. Zuerst, ich probiere auf Deutsch. Vielen Dank für diese Einladung. Ich freue mich sehr. Es ist auch eine sehr interessante Parterre. Ich habe schon mit ein paar Leuten geredet. Viele kommen aus wissenschaftlichen Bereichen. Ich werde euch erzählen über meine alltägliche Arbeit. Es ist inzwischen Women's Brain Project und was ich mache mit meinem Engagement für Pharmaunternehmen, für Start-up. Jetzt ist es Zeit für eine schweizerische Start-up, die aber in die Hände von Amerikanern jetzt gewechselt hat. Es ist leider so, auch mit die Biogen-Medikamente. Es wurde hier in Zürich entdeckt, es wurde dann von Biogen, ehemalige Schweizer Firma, in Amerika gebracht, in Amerika zugelassen und leider in der Schweiz noch nicht da, wo wir hoffen, das sein sollte. Aber das ist eine andere Geschichte. We start. I was told that I have to look there, so very good. I'm looking at you and I take this in my hands. Erste Frage, hat jemand schon etwas gehört über Women's Brain Project vielleicht? Okay, gut. 3 Leute, 4 mit Ihnen. So I have to tell you what we do. This is not good. I want that everybody knows very well at the end of the day what we are doing. Und was wir machen, es ist eigentlich Forschung über wie Geschlecht einen Beeinfluss haben kann über Gehirnerkrankungen und psychische Erkrankungen und eigentlich in die ganze Medizinumfeld. What do we mean with gender? Auf Deutsch es ist nur ein Wort. In English we can say sex and gender. So when we say sex and gender we have 2 different meanings. One, it's about the DNA, so the sex of an individual, what it is in our genetic code and what we carry on with genes, with proteins, with microbiomics, with you name it, you have it. And the gender, it is more towards the social construct that an individual might decide to choose within a given societal context or the role that the society is giving to the individuals. This is what we refer as gender. And our studies are showing that both sex and gender have an influence on how we disease. So it's not about studying who of us can park better a car. It's not about that. It's really about understanding how those differences have an impact in our well-being and the way we receive care, the way we are embedded within an health care system. And I find this is extremely important because in the end it translates on how a treatment can have an effect on our body, but also how the safety profile of a drug can be characterized, whether the person who is taking the drug is a man or a woman. And this interest in sex and gender medicine started with me also because I worked at Swissmedic, which is the Swiss Agency for Therapeutic Products Approval, for 4 years. I was a clinical reviewer. And while looking at all the data that I was privileged to look at, because I think there are just few people in the world that can really see the whole data set of a phase 3 trial, of a phase 2 trial, etc., I realized that yes, there are differences in how men and women respond to treatments in clinical endpoints, also in the safety profile. And so I started to develop that curiosity. My father was a police inspector, so I was, I think, inheriting from him this attitude of asking why, and I was doing the inspector job, going back to the pharmaceutical industry and asking why we have that women have more bellyache than men, and why do men have more headache than women. So, and that's how it started. I have to say that the work we do at the Women's Brain Project, it's a pioneering work. We can be very proud of saying that we have been one of the first organization of scientists in the world to initiate this debate. And even today I got a message from one of my team saying, oh look, there is a new article on Nature pointing to the fact that science has to take much more into account these nuances of sex and gender differences, of course, in preclinical science as well as in clinical development. So the journey is from the beginning till the very end. So about myself, I think that I was properly and wonderfully introduced, so thank you very much. I am doing this job on a pro bono base, meaning that I dedicate my free time and my maybe private time to this endeavor, but there is a purpose. So if there is a purpose, there is the joy of doing what one is doing. And I think that this is true also for all the scientists that are behind the organization, because I am, let's say, one of the most senior person within the organization, but I have 60 people behind me from across geography, from all over the world, that are supporting the cause. Also, most of them on a pro bono base, and that's phenomenal. Now, some facts about Switzerland and women. For example, if you look at these slides, you can appreciate that life expectancy, it is increasing both for men and for women. That's certainly true. For women, it is even more obvious that they tend to live longer in Switzerland. But what about the quality of aging? How do women get old? Do they age well, or do they age in a bad shape? And actually what we know is that when you look at the morbidities that women do experience, they live longer, but they have much higher number of morbidities, which means they have more pain, they have more chronic diseases, they have inflammatory diseases, etc., not to mention, for instance, depression, because we know that majority of the people living with depression are female, and it increases also with age. Unfortunately, what we also know is that women also have more dementia than the male population. And there is a study that will be published, I think, in the next couple of weeks, which points to the fact that it's not only that it's not a matter of women living longer and that's why they have more dementia. In fact, the risk, it's already obvious in the phases where the disease is not yet manifested, because we know that Alzheimer's, unfortunately, begins 20 years before the symptoms start to be obvious. And this study that we just did with a group of scientists, it's a modeling system pointing, as I said, to the fact that already in the early phase of the disease, when there are no symptoms, it seems that women are at much higher risk. So meaning that it's not just a matter of women living longer. There are other things that we need to understand what it's all about. When we look at always in Switzerland, at the percentage of the population taking painkillers or taking, unfortunately there is one word missing there, taking sleeping pills or hypnotic drugs. Again, what we know, and proves what I've just said, is that the higher consumption of painkillers as well as sleeping pill, anxiety pills in Switzerland is consumed by elderly women. And it speaks for the fact that something is there. The quality of life, it is certainly not what it should be. Now, when we look at sex and gender differences in brain and mental diseases, we have certainly the possibility of looking at a bias, if you wish, already in the numbers of those diseases. For example, you have that Alzheimer's, as I said, it is more female. You have depression, that it is more female. 80% of the patients are women when depressed. Anxiety, it is exactly the same thing. Migraine, we have even long COVID seems to be more in the female population versus the male one. Etc., etc. Then there is one disease on which I'm very passionate, also listed here, which is called NMDA receptor encephalitis. I think this is a clear example of the bias that exists in the medical field, because the anti-NMDA receptor encephalitis, it is quite a new disease. It has been, I think, included in the ICD code in 2007, if I recall correctly. Before, it was believed that those women that had this encephalitis were just out of their mind. They were, hysteric, crazy, or whatever. They, maybe in my home country, where I'm coming from, they were treated with this, it's called taranta, this hypnotic type of dance, because the devil was possessing the lady. And the fact that the devil possession was there derives from the fact that those women had actually very often a teratoma, which is a tumor, a benign tumor of the ovary, and this tumor produces antibodies against the brain. So the brain goes on fire, this becomes an encephalitis, the person can die out of it, but what happened? They were locked in a psychiatric ward, forgotten, and thinking she's just becoming hysteric or the devil is possessing her. And the devil comes because when they were doing autopsies or opening the belly, they would have found a teratoma that had eyes, that had hair, that had teeth, because that's the feature of a teratoma. And they were thinking, that's the son of the devil, you know, that's what it was. That's medicine, isn't it? And finally, we have understood that this is a disease, that there are antibodies produced by this type of tumors that put the brain on fire. And I assume that still it's not that easy to recognize the symptoms. Many women are diagnosed too late or misdiagnosed, and this is true in Switzerland. I don't know what's happening in, you know, developing in low and middle income countries where medicine is not yet that advanced. I still believe that those ladies might have some guru or some trying of exorcism to remove their possession from a devil or whatever. And then we have also the other story, which is the male bias, because we have some diseases that are known to be more present in the male body. For example, Parkinson or ALS or strokes that occur in the midlife phase of our life. Is it just a matter of numbers? This is about prevalence, so it's really about how many people. I think, and we are showing clearly that differences are also in many other domains. So it's not only about numbers. Actually, the sex and gender differences are found in specific risk factor, and I will tell you later about it, in biomarkers, so how a biomarker it is expressed in an individual, whether man or woman. Symptoms, because very often the symptoms of a disease, especially when it's about brain and mental disorders, might be different. So I give you an example. If you have Alzheimer's, based on my whole days and my whole experience, very often in a woman starts with depression, with she is perceived like strange behavior, and very often she's treated for depression with antidepressive drugs, and then after 2-3 years it turns out to be, she has a cognitive impairment, this is the beginning of a dementia. And vice versa, for the men it's more like the aggressivity trait. Men become more aggressive, they become more, it's part of how we function and how we differ, if you wish. The same is true for progression. We know that diseases progress differently, whether it's a man or a woman being sick. Women tend to progress faster with Alzheimer's disease, for example, twice as much, which is a significant number because it means the cognitive decline, it's really much steeper. And of course, drug response. I mean, in this room we have amazing backgrounds. I don't think I have to give any hints on how the metabolism in terms of pharmacokinetic, pharmacodynamic of the female body differs from the male one. Now, if you ask me whether this is really taken into account into clinical development, I will say that some improvements are done in pharmacokinetic, especially when it's a drug that has a suspect of having some effect on our heart and potentially cause arrhythmias, because we know from history, and I will show you some data later, that there have been often drugs that were withdrawn from the market because women died because they caused little fatal arrhythmias. And so there we have a bit of an attention, but the rest, it's really a long journey to be done, and that's why we do what we do. Again, this is an example of these sex and gender differences. This is a case of Parkinson's disease. You see that the patient with Parkinson being a woman, she will have mainly tremors, she might have more of the gastrointestinal dysfunction, which means problem with Verdauung. She might be more prone to fall versus a man that has more often the blockade, the difficulties in gait, and the tendency to be curved. So this is why it is important to investigate those differences, because of course if you're trying to develop a drug that treats one of those symptoms, you need to take into account by whom it's more frequent and which are the nuances in differences in the symptoms. That's our work. I said it. We are very strong into the Alzheimer arena. Of course, we embrace also other indications, migraine, depression. We have profound collaboration with leaders in the field of brain and mental disorders. But where we started, it's really Alzheimer. We were the first people in 2018 to publish a review on Nature Neurology Review, where we collected all the available evidences in the literature is why it was not only about numbers, but there must have been something more. And then the BBC came and asked, so what's going on? And since then we started the journey, because of course if you have the endorsement from the BBC, I think you are on the right track. And I can proudly say that I think 2 days ago, again, the BBC has brought up the problem of neglecting the female aspect in dementia, and they again mentioned the work that we did best in back in the past. So there are sex and gender differences, as I said, also in biomarkers like the genetic biomarker ApoE, but also in the accumulation of biomarkers in the brain. It's shown that women tend to have more of the pathological accumulation of the biomarkers in the brain versus the male population per basically same level of symptomatics. So they have more brain atrophy, they have more brain deposition of toxic protein. And the question is whether all these differences, I've given you now some examples of these differences. The question is it considered into the medical world? Are we doing good science? Are we doing clinical development that take into consideration all these differences? Well, unfortunately, no, that's not yet the case. It's still believed that the woman body, it is a small body of a man, so that the woman is a small man, if you know what I mean. We are starting now to pay more attention to those differences. FDA has become more aware, the NIH as well. There are starting to be guidelines issued on how to consider those differences. Also in preclinical research, as I mentioned, the Nature paper was shared with me actually today, so I have to read the editorial, I didn't have time yet, to encourage all the scientists to consider these differences when they plan their experiments, because it starts in the lab to go then to the translational part. And this is the data I shared with you earlier. This is an obsolete, if you want, evidence, and it has been released by the United States General Accounting Office in 2001. It's obsolete because it's pretty old, but since then no one made such a similar report. So I think nobody dared to look carefully at what happened. But what this report says is that at that time, out of 10 drugs that were withdrawn from the market, 8, it was because they had little side effects in the female population. So it means women died, as I said, highly likely and very often because of this QT prolongation or this arrhythmia problem, let's say, to make it a bit more easy to grasp. And this means, of course, that women eventually had little side effects, but also that we waste years of research, we wasted asset like the money that we put in developing a drug. Usually it takes up to 15 years, 20 years, and it's billions. And finally, the person that might have benefited of this drug, because I'm pretty sure that some people were very happy with these compounds, they don't have the drug anymore in the apotheke. You know, I'm sure that on certain people the problem of these little side effects was not the case. That's why we need precision medicine. We need to go from the concept of shallow medicine to the one of precision medicine. And actually, it's not what I am inventing here, it's what Eric Topol, to quote Eric Topol, is the editor-in-chief, I think, of Medscape, introduced as a concept. Shallow medicine, we should stop doing this, let's move towards precision medicine. And also regulators start to pay attention. This is a quite interesting example of what I'm telling you. As I told you, I was working for the regulatory agency here in Switzerland, so I'm always alerted to things that are referring to regulators and what's happening in the scene. That morning, it was October, I opened up the New York Times and I've read the headlines. FDA approved a new HIV prevention drug, but only for men, not for women. I said, wait a second, how can that be? And actually, I would be interested, you shouldn't read. What do you think is the main reason of this? Don't read, just why do you think that it was approved only for male? Simple. Not even one woman included, not even one single woman in the trial. They just didn't put women. So like if women wouldn't have HIV, that would be fantastic. But I think that unfortunately we have the opposite trend, that heterosexual female are more on the rise of getting the infection versus the homosexual community. And I think the FDA did the right thing, because if you don't show me data in a given population, why should I approve you the drug for everybody? And in this trial design, they've recruited basically, it was more like on how to have that type of intercourse or sexual intercourse, rather than thinking which are the patients that might have the HIV problem. So, and this is what we need to certainly solve. As I said, move from the concept of shallow medicine to precision medicine. And what we want to do, we want to establish a sex and gender precision medicine research institute in Switzerland. We are in a dialogue with some authorities in Basel, with the University of Basel. It's not that easy, because it's a long journey to create an institute from the ground. And maybe we will not succeed, but certainly we have already started an international debate that can't be stopped. So that's already good enough. Anyhow, who we are. I didn't tell you who we are. I think I mentioned it in the introduction. We are a group of scientists mainly, but it's not the typical and only medical scientist or neuroscientist. We have all the possible expertise. We have people with a background in pharmacy, in chemistry. We have people who have a background in data science, engineers. It's really diverse. And I think that's our strength, because we've put together a team of diverse expertise, diverse geography, and maybe even diverse attitudes. And we work together with people that have nothing to do with science. So since the beginning, we brought in actresses, or philanthropists, or some policymakers, people expert in communication, because you might have the best idea in the world. If you do not communicate it properly, it doesn't go anywhere. And I strongly believe that, I love a sentence, I don't remember where I've read it, but which says that the future belongs to those who can tell the story. So if you keep on telling the story the right way, then you shape the future. And that's why we also put in the team people with an expertise in communication. It's also about generating the awareness. So we distribute a lot of our knowledge within the lay public, and we work with the lay public organization, with patients organization, with caregivers organization. So it's this 360-degree approach that I think I really encourage within the organization, because coming from the pharmaceutical world, the hospital, the research, the regulators, I think I was seeing it all, and what I've always missed was this open discussion with all the interested parties, because pharma, it's in a silo, pharma and regulators, no, we cannot speak with pharma, we cannot speak with patients, nobody speak with one another. In the end, you don't solve the problem. And so we want to create this institute which will generate the evidences as why sex and gender research matters, that will bring the expertise also outside of the institute, acting as, if you wish, on a consultancy advice role for anyone who is interested to learn, like today, for example, and then generating awareness on our data, so the communication part, as I mentioned. This is a bit of a flavor of what this means. It means in scientific publication, peer-reviewed journals, of course. It means organizing events. We have been doing the so-called forum on the International Forum on Women's Brain and Mental Health. We're going to plan now the 4th edition in 2023. The forum has brought together scientists, the regulators, the OECD, WHO, you name it, you have it all together in Zurich, and we discussed about this problem. And that's why I'm saying that we generated this international movement of people interested in sex and gender precision medicine. And the forum, it's a huge animal, how I call it, because it's big. So we're trying to take a breath, because we did the last one fully online. It was 2020. We were the first organization, I think, in the world to do a full forum, full virtual event that it's all visible on YouTube. But it's a big endeavor. So we thought of doing it for 2023. We teach, so we are present at the University of Zurich, where there is a curricula. There is a course of advanced study on sex and gender medicine, and we are teaching there. We also do this within other organizations, other universities around the world. We have strong collaborations, again, globally, and then, I don't know how it happened, but this brings you to receive certain type of prizes. We heard it before. I would have never expected that life would have turned to be the way it did, but it means it gives the recognition. And at the beginning you think, now why should we get a prize? I mean, scientists, at least I wasn't used to receive any prizes, and my father taught me whatever you do, it's just half of what you're meant to be doing in this planet. But then you start to think, well, maybe it's a recognition of the hard work, and maybe there is a value in what we do, and then you start to believe even more to do even better. This is an interesting publication on which we are still working, but has been resubmitted actually, I think, a couple of days ago by our Chief Scientific Officer, Dr. Maria Teresa Ferretti. And it says that since we started, basically, this is around 2015, you can see here, the number of publications that look at sex and gender differences in neuroscience and in cardiovascular research basically spiked. So that's what I've told you. We have tangible proof that what we did was really meaningful, and our forum, our discussions, our engagement, it's really changing the outcome of science, because more and more scientists are looking at those differences in their clinical research. And now I give you a little bit of a funny story. This is about the famous sex and gender differences in the brain. And you heard that in the introduction, I am now having the role of Chief Medical Officer at Altoida. And Altoida is another Swiss great idea from actually a Greek scientist that was doing his neuroscientific work here in this beautiful country. And Johannes had the idea that to diagnose Alzheimer, he would have needed something else than usual business, like the neuropsychological tests that we used to run, that I used to run even in the clinic when I was working as a doctor. And that's because his grandmother was having Alzheimer, and they realized that those neuropsychological assessments she was doing were not really reflecting the daily living of that woman. And he thought, I have to develop a test that capture the real mode of function of an Alzheimer brain and diagnose it much faster and more accurately. So what he did was to create a piece of artificial intelligence, which basically can, in 15 minutes test on your portable device, whether an iPad or an iPhone, tell you if your brain has Alzheimer, if it is cognitive impaired, or if it has, if it functions the right way. And I found these findings so, in a way, revolutionary, because I thought there is a potential to learn much more than only Alzheimer. If this is a tool where you take a test with augmented reality and you do it in 15 minutes when you receive orders to be done, in fact, it studies how the brain works and can be applied to anything. It has potential for any other possible indication, brain disease, whatever. But then I had the question, Johannes, do me one favor, you and your team of scientists, please tell me if your device can tell me if the brain of the performer is a female or a male brain. And he was like, we have no time for doing that. And I said, come on, Johannes, please do me this favor. And every time I used to meet him, I was again posing the same question. Then I got a phone call from Robert, who is a scientist in his team, and he says, Antonella, you know what? We finally did what you told us. And actually, our classifier can distinguish pretty well if the person taking this cognitive test, it's a woman or a man. And so, now, what does it mean? We still don't know which are the real clinical implications of all this. What we know is that the classifier is not able to discriminate anymore when dementia becomes obvious, meaning when the brain is really not functioning anymore, so all these differences are lost. But this indicates that, in fact, those type of learnings, when you embed it in any other type of modeling, how the algorithm recognize disease, it can depict it and eventually tell us more about clinical endpoints or how to monitor or how to diagnose. So that's a bit what we do. Another thing that I want to present to you, it is projects that are currently ongoing. This is a project with The Economist. We are doing a modeling study and health economic modeling study on understanding if we neglect these sex and gender differences, in the end, how much do we lose or gain in terms of economical revenues. And I think that's important because, again, it's that type of 360-degree work you need to do with all stakeholders. So we want to go with this piece of evidences branded by The Economist to the policymakers, because, if they read The Economist, then they certainly think, oh, that's true, and say that's what we need to do. So it's the co-creation piece with multiple stakeholders, and then with this result, go and educate policymakers on the value we bring on the table. Another project that we are doing with Charles River Associate, which is, let's say, one of the main consultancy company in the field of life science, it is what we call the blue and pink patient journey. Now, the patient journey, it is what it serves all stakeholders in a given disease area to understand where is my patient, when the symptoms start, when do I prescribe, what happened to my patient, which is the safety profile. So it's really the journey of an individual with a disease from onset till either the cure or, unfortunately, the exitus. And actually, we are, again, the first one which came with this idea. We said, okay, if sex and gender difference really exists in Alzheimer's, then how the patient journey differ? Must be also a different journey for a woman as compared to the man. And so we are now doing this patient survey that will be US and Germany based, and we will generate the evidences to build then on that type of narrative. Another thing that we are doing, and then I think I'm going towards the end, it's a roundtable. We already had 2 roundtables with regulators. So we have invited the Food and Drug Administration, we have invited the European Medical Agency, we have been inviting, the IMI, there was, I think, the Canadian regulators at the table, I think even the Australian, if I don't recall wrong, to discuss what it takes to ameliorate the status quo of clinical guidelines for developing new treatment and considering sex and gender differences to achieve precision medicine. We are going to do hopefully a third one in Berlin around the World Health Summit. That it's an yearly event happening in Berlin. This year it's going to be also with the endorsement of the WHO. And again, it's an opportunity to educate across disciplines as why this matters. So why we want to do this, I'm arriving at the end of my talk, and I'll be glad to take any questions you wish to pose. We want to do it mainly because we believe that there is a space for improving drug efficacy, so how a drug is really working. The safety profile will be certainly also improved if we start to consider these differences from the very early onward. And it will ameliorate also adherence and compliance. I mean, how a patient adhere to a given treatment. And finally, it will reduce certainly the cost of failing of drugs, but also the side effects, because when you have side effects given to, for instance, polytherapy, and we know that even in that case, it's more in the female population, in the elderly population, that you have that side effects are more severe and lead to an hospitalization. This will increase the cost. So we want to do all this also to reduce the cost of the healthcare system and move towards the sustainability piece. So if you look at the UN Sustainable Goals, I think that we can proudly say that the work of the Women Brain Project, it's certainly spot on. This is the team. People come and go, and I think that now we are even more, but it gives you a flavor of who we are and all the people behind me. I want to thank them for sure, and thank you for listening and having me today with you. Finally, but not least, we said about communication. So you can find us everywhere, and that's the beauty of it and the burden of it, because there is also the unspoken side of things sometimes. So that's it. We're on Instagram, on Facebook, on Twitter, and LinkedIn, and it's enough for now.